The term multiple endocrine neoplasia encompasses several distinct syndromes featuring tumors of endocrine glands, each with its own characteristic pattern. In some cases, the tumors are malignant, in others, benign. Benign or malignant tumors of nonendocrine tissues occur as components of some of these tumor syndromes. MEN syndromes are inherited as autosomal dominant disorders. Terminology: the older names, multiple endocrine adenomas, and multiple endocrine adenomatosis, have been replaced by the current terminology. The term multiple endocrine neoplasia is used when two or more endocrine tumor types, known to occur as a part of one of the defined MEN syndromes, occurs in a single patient and there is evidence for either a causative mutation or hereditary transmission. The presence of two or more tumor types in a single patient does not automatically designate that individual as having MEN because there is a small statistical chance that development of two sporadic tumors that occur in one of the MEN syndromes could occur by chance. The term multiple endocrine neoplasia was introduced in 1968, but descriptions of the condition date back to 1903. Related conditions, although not officially categorized as multiple endocrine neoplasia syndromes, von Hippel-Lindau disease and Carney complex are two other autosomal dominant endocrine tumor syndromes with features that overlap the clinical features of the MEN syndromes. Although not transmitted in the germline, McCune-Albright syndrome is a genetic syndrome characterized by endocrine neoplastic features involving endocrine glands that overlap with those involved in MEN1 or MEN2. History: in 1903 Erdheim described the case of an acromegalic patient with a pituitary adenoma and 3 enlarged parathyroid glands. In 1953 Underdahl al. reported a case series of 8 patients with a syndrome of pituitary, parathyroid, and pancreatic islet adenomas. In 1954 Wormer noted that this syndrome was transmitted as a dominant trait. In 1959 Hazard al. described medullary thyroid carcinoma. In 1961 Sippel described a combination of a pheochromocytoma, medullary thyroid carcinoma and parathyroid adenoma. In 1966 Williams al. described the combination of mucosal neuromas, pheochromocytoma and medullary thyroid carcinoma. In 1968 Steiner al. introduced the term multiple endocrine neoplasia to describe disorders featuring combinations of endocrine tumors and proposed the terms Wormer syndrome for MEN1 and Sippel syndrome for MEN2. In 1974 Sizemore al. showed that the MEN2 category included 2 groups of patients with MTC and pheochromocytoma, one with parathyroid disease and a normal appearance and the other without parathyroid disease but with mucosal neuromas and mesodermal abnormalities. In 1988 the MEN1 locus was assigned to chromosome 11. In 1993 mutations in the RET oncogene were shown to be the cause of MEN2A by Lois Mulligan, working in the laboratory of Dr. Bruce Ponder in Cambridge. In 1998 the MEN1 gene was cloned. Comparison. Percentages in table below refer to how large fraction of people with the MEN type develop the neoplasia type. Of patients with MEN1 and gastrinoma, FMTC equals familial medullary thyroid cancer. MEN2B is sometimes known as MEN3 and the designation varies by institution. Although a variety of additional eponyms have been proposed for MEN2B, none ever gained sufficient traction to merit continued use and, indeed, are all but abandoned in the medical literature. Another early report was Skimke al. in 1968. OMIM also includes a fourth form of multiple endocrine neoplasia, associated with CDKN1B. The presentation is believed to overlap that of MEN1 and MEN2. Multiple endocrine neoplasia type 1, the MEN1 gene. The MEN1 gene consists of 10 exons, spanning about 10 kilobytes, and encodes a 610 amino acid protein named menin. The first exon and the last part of exon 10 are not translated. A main transcript of 2.8 kilobytes has been described in a large variety of human tissues. An additional transcript of approximately 4 kilobytes has been detected in pancreas and thymus, suggesting a tissue-specific alternative splicing. The menin protein. Menin is a 610 amino acid nucleoprotein, highly conserved from mouse, rat and, more distantly, zebrafish and Drosophila. Human and mouse MEN1 amino acid sequences share 95.8% identity and 98.4% similarity. Analysis of menin amino acid sequence did not reveal homologies to any other known human or mammalian protein, sequence motif, or signal peptide. The absence of significant homology to any other protein complicates efforts to elucidate the functions of menin. Pathophysiology. MEN1 follows Nutsoni Euro1 registered trademark SA Euro 080 HETA Euro model for tumor suppressor gene carcinogenesis. The first hit is a heterozygous MEN1 germline mutation, inherited from one parent or developed in an early embryonic stage and present in all cells at birth. The second hit is a MEN1 somatic mutation, usually a large deletion, that occurs in the predisposed endocrine cell as loss of the remaining wild-type allele and gives cells the survival advantage needed for tumor development. Mnemonic. A useful mnemonic to remember the associated neoplasias is below: Benign, pituitary, parathyroid, pancreatic, meningeal, medullary thyroid car, pheochromocytoma, parathyroid, Benign, medullary thyroid car, marfanoid habitus mucosal neuroma, pheochromocytoma, MEN1 mutations in multiple endocrine neoplasia patients and clinical genetics. MEN1 gene mutations can be identified in 70 to 95% of MEN1 patients and in about 20% of familial isolated hyperparathyroidism cases. Almost all patients are heterozygous for mutations. One affected family has been identified with individuals both homozygous and heterozygous for MEN1 mutations. In this family, there was no difference in disease history between the homozygous and heterozygous mutation carriers. 50% of patients develop signs and symptoms by 20 years of age and more than 95% have symptoms by 40 years of age. There is significant intra- and interfamilial variability in the age of onset, severity of disease, and tumor types. Despite numerous studies, no genotype-phenotype correlations have been established, suggesting that unknown genetic and environmental modifiers are involved in the expression of the MEN1 phenotype. Manifestations. Multiple endocrine neoplasia type 1 is a rare hereditary endocrine cancer syndrome characterized primarily by tumors of the parathyroid glands, endocrine gastroenteropancreatic tract, and anterior pituitary. Other endocrine and non-endocrine neoplasms including adrenocortical and thyroid tumors, visceral and cutaneous lipomas, meningiomas, facial angiofibromas and collagenomas, and thymic, gastric, and bronchial carcinoids also occur. The phenotype of MEN1 is broad, and over 20 different combinations of endocrine and non-endocrine manifestations have been described. MEN1 should be suspected in patients with an endocrinopathy of 2 of the 3 characteristic affected organs, or with an endocrinopathy of one of these organs plus a first-degree relative affected by MEN1 syndrome. MEN1 patients usually have a family history of MEN1. Inheritance is autosomal dominant. Any affected parent has a 50% chance to transmit the disease to his or her progeny. MEN1 gene mutations can be identified in 70 to 95% of MEN1 patients. Many endocrine tumors in MEN1 are benign and cause symptoms by overproduction of hormones or local mass effects, while other MEN1 tumors are associated with an elevated risk for malignancy. About 1/3 of patients affected with MEN1 will die early from an MEN1-related cancer or associated malignancy. Enteropancreatic gastrinomas and thymic and bronchial carcinoids are the leading cause of morbidity and mortality. Consequently, the average age of death in individuals with MEN1 is significantly lower than that of the general population. Recommended cancer surveillance. A recommend surveillance program for multiple endocrine neoplasia type 1 has been suggested by the International Guidelines for Diagnosis and Therapy of Men's Syndromes Group. See also, multiple endocrine neoplasia type 1, multiple endocrine neoplasia type 2A, multiple endocrine neoplasia type 2B, references. External links, Endocrine and Metabolic Diseases Information Service, the Association for Multiple Endocrine Neoplasia Disorders, Multiple Endocrine Neoplasia Type 2.